அப்படியே ஸ்டார்ட் பண்ணுங்க.
இல்ல என்னோட இதுக்கு ஸ்கிரீன் ஷேர் ஆக மாட்டேங்குது. ஸ்கிரீன் ஷேர் ஆக
bro, இப்போ ஓகே பாருங்க.
Yes. Okay, bro. Okay. So good evening, everybody. Yesterday we have talked about the anatomy, and speaking about the anatomy, we have discussed the various high yield areas, and in the high yield areas we have talked about in the region by region, like head and neck, abdomen and pelvis, and like upper limb, lower limb, thorax. Everything has been discussed. Speaking about that, the last portion of the anatomy was not done yesterday due to the technical glitch. Now we have been doing that last like the last division of anatomy. So speaking about that, we are going to do we are going to do the embryology, the last session of your anatomy, and then we're going to talk about a few miscellaneous topics where we cover the important and high yield areas in anatomy, and then we move on to physiology today. So at the beginning, we are going to initiate the leftover anatomy, yesterday's anatomy, and then we can continue with the physiology. So speaking about the last part, so the part we are going to cover here is your embryology, which is a very, very important one you have to remember. So speaking about the embryology, the very first thing is like we have this pharyngeal apparatus, which is considered to be one of the very, very high yield area for FMGE. So pharyngeal apparatus consists of pharyngeal arches. Pharyngeal apparatus consists of pharyngeal arches, pharyngeal groove, pharyngeal pouch, and pharyngeal membrane. Pharyngeal membrane. So now we are going to first talk about the pharyngeal arch. So what are the pharyngeal arch we are having, and what are the derivatives of each pharyngeal arch we need to know. So speaking about that, pharyngeal arch is derived from somatomesoderm. Somatic mesoderm along with the neural crust cells. Somatic mesoderm along with the neural crust cells. And lack of a migration of the first pharyngeal arch is seen in Treacher-Collins syndrome. Lack of the migration of first pharyngeal arch is seen in Treacher-Collins syndrome. Okay. Now, speaking about the derivatives of your pharyngeal arch. So the derivatives of your pharyngeal arch are totally, we are having 6 pharyngeal arches. Among them, the 5 disappear soon after the formation. So we can say like pharyngeal arch 1, 2, 3, 4, and 6. Pharyngeal arch 1, 2, 3, 4, and 6. Now we are having each and everything is having their own derivatives, like like skeletal. So what are the bones which has been formed from this pharyngeal arch? Muscles, nerves, and artery. We are going to discuss one by one. And then we will talk about what are the things to remember in this pharyngeal arch. Okay, so moving on to that. So skeletal derivatives of your pharyngeal arch 1 is given like malleus, and then to incus, and then you have the spinomandibular ligament, and then maxilla, mandible, zygomatic, temporal, sphenoid, and omer. How I used to remember is like we are having a multiple M's. Okay, we are having a multiple M. Make the sky multiple M makes the sky slow and volatile. So M stands for malleus, another M stands for maxilla, another M stands for mandible, and T stands for temporal, and S stands for 2S stands for sphenomandibular ligament and the sphenoid bone, and V stands for vomer bone. And apart from that, you have to remember the zygomatic alone. Okay. Apart from that, you have to remember this zygomatic alone. So what are the skeletal derivatives of your pharyngeal arch 1? Multiple limbs make the sky slow and volatile. That is a malleus and incus, and then sphenomandibular ligament, maxilla, mandible, zygomatic, temporal, sphenoid, and omer. Temporal, sphenoid, and omer. Then what are the pharyngeal arch 2 derivatives? Pharyngeal arch 2 skeletal derivatives could be said as in the form of 5S people. In the form of 5S. Stapes, styloid, stylohyoid ligament, and a small horn of hyoid, and superior surface of your hyoid. All the 5S comes from pharyngeal arch 2. So speaking about this, pharyngeal arch 2 is easy, and the pharyngeal arch 1 is a little bit like you have to remember with the mnemonic. And then pharyngeal arch 3, 4, and 6 are simple ones. For example, 3 gives rise to greater horn of hyoid and inferior surface of hyoid, while 4 gives rise to thyroid cartilage and epiglottis, and 6 gives rise to the remaining structure of your remaining cartilaginous portion of your larynx. Okay, remaining cartilaginous portion of your larynx gives rise to this pharyngeal arch 6. Okay, so what are the things in the skeletal area you have to remember, people? Number 1, you have to remember in case of your pharyngeal arch 1 and pharyngeal arch 2 derivatives. How do we remember the pharyngeal arch 1 derivative? Everybody, how do we remember the pharyngeal arch 1 derivatives? What is the mnemonic for that? One whomsoever present to type faster, keep your hands on the keyboard and try to talk more and more so that you will learn more and more. So what are the things? What is the mnemonic we used to remember for the pharyngeal arch 1? Multiple M makes the sky slow and volatile. So multiple M stands for malleus and maxilla, mandible, sphenomandibular ligament, temporal, and then you have the sphenoid ligament, and then you have, sphenoid bone, and then you have the vomer, zygomatic, and incus. Okay. And what are the pharyngeal arch 2 derivatives? How many S's you have to remember? 5S, people. What are the 5S of pharyngeal arch 2? What are the 5S of pharyngeal arch 2? Stapes, styloid, stylohyoid ligament, small horn of hyoid, and superior surface of your hyoid. Superior surface of your hyoid. Apart from that, there are 3, 4, and 6 derivatives which are very easy. Greater horn of hyoid and inferior surface of the hyoid 1 comes under the 3. Thyroid cartilage and epiglottis comes under 4. And remaining cartilaginous portion of your larynx comes under 6. And then for the muscles of mastication is pharyngeal arch 1. Muscles of facial expression is pharyngeal arch 2. Apart from that, you have the stylopharynx muscle, pharyngeal arch 3. And you have those muscles of pharynx, palate, and the cricothyroid is pharyngeal arch 4. And all muscles of larynx except the cricothyroid is pharyngeal arch 6. Very, very important MCQ. All the muscles of larynx except the cricothyroid, which is derived from pharyngeal arch 4, are the rest all derived from pharyngeal arch 6. Very, 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 very important anatomical MCQ that you should not miss. So all the muscles of larynx are derived from what pharyngeal arch? All the muscles of larynx are derived from what pharyngeal arch? Pharyngeal arch 6, except the exception is cricothyroid muscle, which is derived from what pharyngeal arch, people? Which is derived from what pharyngeal arch? Cricothyroid is derived from pharyngeal arch 4. Okay, muscles of pharynx, palate, and like a cricothyroid comes from 4, while muscles of larynx except cricothyroid comes from 6. You have to remember that. Muscles of mastication, that is pharyngeal arch 1. Muscles of facial expression, that is pharyngeal arch 2. And then we have the nerve. What are the nerves you have to remember? The important nerves, the nerves which is derived from pharyngeal arch 1 is your mandibular nerve. The nerve which is derived from the pharyngeal arch 1 is your mandibular nerve. And then 2 is facial nerve. 3 is glossopharyngeal nerve. 4 is vagus nerve, except the superior laryngeal nerve. Vagus nerve, including the superior laryngeal nerve. and pharyngeal arch 6 is recurrent laryngeal nerve. Okay, and pharyngeal arch 6 is recurrent laryngeal nerve. So we used to say that all of the muscles of the larynx are supplied by recurrent laryngeal nerve, except cricothyroid, which is supplied by superior laryngeal nerve. Okay, you have to remember that. In that way, also the question may come to you, people. You have to remember in both ways. Okay, either from the pharyngeal arch or from the neural innervation. They may ask you this question that you have to remember. Okay. So speaking about the nerves, mandibular 1, facial 2, glossopharyngeal 3, and vagus 4, and the recurrent laryngeal nerve is 6. And artery, the artery comes from the derivatives of your pharyngeal arch. 1 is maxillary artery, and 2 is stapedial artery, 3 is common carotid artery and the first part of ICA, and 4 is right subclavian artery, and a part of arch of aorta, and the arch of aorta between your left common and left subclavian. That part is derived from pharyngeal arch 4. And then pharyngeal arch 6, you have the pulmonary artery and ductus arteriosus. Pulmonary artery and ductus arteriosus. So these are the important things you have to remember in the case of your pharyngeal arch, people. So speaking about the pharyngeal arch, we have talked about all 6 pharyngeal arch. Among them, the skeletal one of 1 and 2 are important. And then you have to remember that all the muscles of larynx comes from 6. All the muscles of pharynx comes from 4. The exception is cricothyroid, which comes from 4. And apart from that, the important nerve is pharyngeal arch 6, recurrent laryngeal nerve, pharyngeal arch 4, vagus and the superior laryngeal nerve, and 3 glossopharyngeal, 2 facial, and 1 is mandibular nerve. Apart from that, muscles of mastication derived from pharyngeal arch 1, muscles of facial expression derived from pharyngeal arch 2, and the stylopharyngeus muscles derived from pharyngeal arch 3. And then you have the arteries, especially the maxillary 1 and the stapedial 2, common carotid and the first part of internal carotid artery, which is a pharyngeal arch 3, right subclavian and the arch of aorta between your left common carotid and the left subclavian is derived from this your pharyngeal arch 4. And then you have this pulmonary artery and you have this ductus arteriosus, which is pharyngeal arch 6, Okay. Apart from that, you are having a pharyngeal groove. We are having a first pharyngeal groove, which gives rise to epithelial lining of your external auditory meatus, while rest of the pharyngeal grooves are obliterated. So there is nothing important in the pharyngeal groove. So we have discussed in the pharyngeal apparatus, pharyngeal arch and the pharyngeal groove. The next area is your pharyngeal pouch. Speaking about the pharyngeal pouch, we are having a 5 pharyngeal pouch. What are the 5 pharyngeal pouch we are having, people? 1, epithelial lining of your auditory tube and middle ear and the mastoid air cells comes from the pharyngeal arch 1. What are the things which comes from pharyngeal arch 1? Epithelial lining of your auditory tube, middle ear, and mastoid air cells. And pharyngeal arch 2, epithelial lining of your tonsillar fossa gives rise to pharyngeal arch 2. And then we have this ventral. Pharyngeal arch 3 have a 2 portions, ventral portion and dorsal portion. Ventral portion is thymus and dorsal portion is inferior parathyroid 1. Dorsal portion is inferior parathyroid 1. And fourth one contains only the ventral portion, which gives rise to ultimobronchial body, which later forms as parafollicular cells. If they ask you the origin about the parafollicular cells, you have to say neural crust cells over your ultimobronchial body. Very, very important one. If they are giving you what is the origin of your parafollicular cells, there will be 2 options given to you. Either it may be like a neurocrust cells or maybe like a ultimobronchial body. So, okay, if they are given any of this, to choose the neural crust cells over the ultimobronchial body. And fifth one, dorsal one, which contains a superior parathyroid 1. Apart from that, you have the this third and the fourth pharyngeal pouch have to be differentiated. There is an improper differentiation or absence in the differentiation of your third and the fourth pharyngeal pouch, which in turn results in the thymic hypoplasia, because thymus comes from the third, which is seen in the DiGeorge syndrome. Where is the DiGeorge syndrome? 22q deletion is your DiGeorge syndrome, where you see the absence in the differentiation of your third and the fourth pharyngeal pouch, where you see the thymic hypoplasia, people. Then you have a pharyngeal membrane 1, only one, which forms your tympanic membrane, while rest all will be obliterated. obliterated. So these are the important things you have to remember in the case of your embryology, especially pharyngeal apparatus, the high yield area where you may expect a question. So you should not miss that things, people. You should not miss that things. Very, 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 very important. These 2 pages are. Okay, then you have this lymphatic drainage. So speaking about the lymphatic drainage, so the area of your lymphatic drainage are pretty important. The nodes on the area of body drain. So number very, very important is your para-aortic, which drains your testes, ovaries, kidneys, and uterus. The very, very important one is your para-aortic, which drains on your testes, ovaries, and kidneys and uterus. Apart from that, you have the internal iliac, which drains on your lower rectum to anal canal above the pectineal line. Above the pectineal line. Okay, internal iliac above the pectineal line. Below the pectineal line, it's superficial inguinal. That's the place where they may twist the question, people. So above the pectineal line, it's the internal iliac lymph node. Below the pectineal line, it is a superficial inguinal lymph node. Okay. Apart from that, you have the skin below the umbilicus, except the popliteal areas are drained by your superficial inguinal. And apart from that, you may have this celiac one. Celiac supplies all your internal GI organs like a liver, stomach, spleen, pancreas, and upper duodenum. And the lower duodenum to splenic flexure, you may have the superior mesenteric. And the colon from splenic flexure to upper rectum, you have the inferior mesenteric. You have the inferior mesenteric. Apart from that, the lungs drains into the hilar, and the trachea drains into the trachea, and esophagus drains into the mediastinal one. Trachea and esophagus drains into the mediastinal one. So the lymphatic one, the very, very important ones are, number 1 is your para-aortic, where the uterus, testes, ovaries, and kidneys will be drained by your para-aortic, and internal iliac and the superficial inguinal. They may differentiate here. Above the pectineal line, it's internal iliac, and below the pectineal line, till the anal canal, above pectineal line is internal iliac, and anal canal below pectineal line is superficial inguinal lymph node. Superficial inguinal lymph node. That you have to remember, people. That you have to remember. So these are the important things in the anatomy that you have to remember so far. So we have done with the anatomy. Shall we move on to the physiology? If so, type yes on the chat box. If you want me to proceed to the physiology, type yes on the chat box. Or you need 5 minutes to revise the entire anatomy that we have taught yesterday and today. Just type yes on the chat box so that we can able to proceed with the physiology today. Shall we proceed with the physiology? Very good. Very good. Speaking about the physiology, you have to know few things in the physiology, people. You have to know few things in the physiology. So the very, very high yield area in the physiology section is your GI and your CVS, your neuro, and your, these 3 are a very high yield areas, while the medium or average areas where, your respiratory and nerve muscle physiology, nerve physiology, and the general physiology are kind of like a medium yield one, while the low yield one is your endocrine physiology, because you study that in a lot of subjects. So being asked in a very specifically from this physiology is very, very rare. Okay, they may ask you, for example, features of hypothyroidism. Either may be a thyroid question from the pathology, or maybe from your surgery. So actual endocrine physiology questions will be a little bit rare. They may not ask you that much, but they will ask you the questions from the physiology, typically from, like a GI tract, and you have this CVS, and then you have this, this respiratory, or maybe these areas are the areas they may expect you to answer most of the question. So we focus on that area, while rest of the areas we give a little touch on the rest of the areas. Will that be okay? Will that be okay? Shall I proceed with the physiology, people? Okay. Speaking about the physiology, so the first area of interest is your general physiology. So general physiology, we are going to talk about the homeostasis. So you know that homeostasis, what does mean by homeostasis? Homeostasis means a state of being normal. That is, all the parameters are to be within the range and the body is performing normally. Okay, body is performing normally is so called as homeostasis. As a physician or as a doctor, our primary goal on a patient is to restore a homeostasis in a particular patient. So any patient with a disease come to you, you have to restore the homeostasis in that patient. That's our technical word. So what is mean by homeostasis? Homeostasis means a state of being normal. And the term homeostasis was coined by Walter D. Cannon. Very, very important MCQ. The term homeostasis was coined by Walter D. Cannon. And homeostasis maintenance, the maintenance of being a normal individual, is done by a control systems in our human body, people. What are the control system? We have three types of control system. One is your negative feedback, another one is your positive feedback, another one is your feed forward control system, another one is your feed forward control system. So how many? Negative, positive, and feed forward. What is negative feedback? You already know that substrate forms a product and raised product will inhibit the substrate. Yes or no? One such classical example is your baroreceptor. And what is positive feedback? Exactly opposite to your negative feedback. Substrate forms a product and increased product will stimulate further the reaction. That is so called as positive feedback. Yes or no? The examples where, like a LH surge and entry of calcium into your sarcoplasmic reticulum and coagulation cascade, action potential, parturition, and shock. One such very, very important question that you may expect in the FMGE, they want to test you in the general physiology. Very rarely they ask a question from the general physiology, but if they ask you, this is one of the classical thing they may ask you. So remembering the examples of positive feedback is very, 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 very important. Okay, LH surge, entry of calcium into sarcoplasmic reticulum, coagulation cascade, action potential, parturition, and shock are the classical examples of your positive feedback system. Then you have the feed forward system where the positive and the negative feedback, you require some stimulus. The stimulus is your raised product. Yes or no? For a feed forward system, there is no stimulus required. There is no stimulus required. One of the very classical question that may be asked in the FMGE in terms of negation. For example, like all of the following are true about feed forward control system, except this type of question is so called as question of negation, where they may give you one incorrect statement and you have to pick up that one incorrect statement. And this type of questions are mostly seen in the feed forward system, especially with the stimulus present. Okay, so no stimulus, you have to remember, no stimulus is required for feed forward system. Okay, feed forward system. One such a classical example is your cephalic phase of your gastric acid secretion. Okay, cephalic phase of your gastric acid secretion is one such classical example of your feed forward system. Okay, now, okay, we talked about the homeostasis, which has been coined by the, like Walter D. Cannon, and we talked about all the three system, all the three examples, all these things. Now, we talk about the body fluids, people. We talk about the body fluid. So consider total body weight as 100%. If you're taking the total body weight as 100% and total body water is 60%, total body water is 60%, and remaining all will be like a protein and a fat and minerals. Okay, out of that 60%, 40% will be your ICF, 40% will be your ICF, and 20% will be your ECF. 20% will be your ECF. Out of this 20% of ECF, 15% is your interstitial fluid and 5% is your plasma, and 5% is your plasma. So you know the weightage now. 100% is body weight. Among the 60% is your body water. Out of that, 40 is intracellular and 20 is extracellular. Out of that 20, 15 is interstitial and 5% is plasma. You knew that. Now, what are the things they may ask you in the FMGE? What type of dye we uses to measure these things is the important MCQ that you have to remember. What type of dye we uses to measure these things is the important things that you have to remember. So I'm going to highlight it in the pink, people, so that you can able to understand the important dyes, and you have to remember that too. Okay, So total body water can be measured by deuterium, tritium, and antipyrine. Total body water could be measured by what? Deuterium, tritium, and antipyrine. And then you have the ECF, because ICF cannot be measured. So ECF, the dyes we use is your inulin, sucrose, mannitol, sodium thiosulfate. What are the thing? Inulin, sucrose, mannitol, and sodium thiosulfate we use this for ECF. And for plasma, we use this Evans blue or radioactive iodinated albumin, where the radioactive iodinated should be 125. I-125 albumin we use this. Most people make some mistake of I-131 here. That's what we use in the hypohyperthyroidism, radioactive iodine. But for a measurement of plasma, what type of radioactive iodinated albumin we are using? I-125 or 131? What type of radioactive iodinated albumin we are using? Iodine 135 or iodine 125 or iodine 131 we are using? Never ever make a mistake, people. Iodine 125 we are using here. We are using iodine 125 here. Okay, never ever make a mistake. Okay, so apart from the major cation and anion, major cation of your ECF is sodium and major anion is chloride, while for ICF it is potassium over the magnesium and major anion is phosphate. So major anion of your ICF is phosphate, for ECF it is chloride. ECF major cation is sodium and the ICF major cation is potassium over magnesium. Okay, potassium over magnesium. Yes, we can give radioactive 125 for also the prostate cancer. Yeah, we can give, no problem. Okay, now speaking about the membrane transport, we are having two types of membrane transport, people. One is towards the concentration gradient, another one is against the concentration gradient. One is towards the concentration gradient, another one is against the concentration gradient. So what are the things which is towards the concentration gradient, which is active or passive, which is going on with the flow? When it going on with the flow, will it be active or passive? Will it be active or passive when it is going on with the flow? It will be a passive one. Okay, and similarly, when it is going something against the concentration gradient, which is opposing something, it is an active transport. Since it is opposing something, it requires energy, right? Yes or no? It requires energy because it is opposing something and pushing against the opposite direction. So does it require energy or not? Yes, it does require the energy. Okay, so how does this energy comes from? For a primary active transport, breakdown of ATP is happening, and for the secondary active transport, which involves your sodium coupled transport, One such a classical example of your primary active transport is your sodium potassium ATPase. You know the pump called as sodium potassium ATPase, right? Where it exchanges the sodium for the potassium by breaking down the ATP. Yes or no? 3:2 ratio. And that sodium potassium ATPase is one of the classical example of your primary active transport. And what is the classical example of your secondary active transport? We have a lot of secondary active transport. One such a classical example is your SGLT, sodium glucose luminal transporter, where glucose will be exchanged for your sodium. Nowadays, in the treatment of diabetes mellitus, we are playing a biggest role with the SGLT2 inhibitors, yes or no? Which is acting on the kidney. Okay, anyway, that we will study in the pharmacology. We will revise that. We will quote the important highlights in the pharmacology session too. But now you have to remember one such classical example of your secondary active transport is SGLT2. SGLT2. Now, speaking about the passive transport, people. We are having a diffusion and osmosis. Well, and the osmosis, we need to know only two important concepts. What is the difference between osmolarity and what is the difference between osmolality? Okay, molarity and the molality are the differences you have to know. Osmolarity means number of osmoles per liter of solution. Number of osmoles per liter of solution is your osmolarity, while osmolality is number of osmoles per kg of solvent. Number of osmoles per kg of solvent is osmolality, while number of osmoles per liter of solution is osmolarity. Okay, is osmolarity. Now, speaking about the diffusion, we are having a passive diffusion and a facilitated diffusion. So passive diffusion, so it does not require any ATP or carrier protein, while the facilitated diffusion, in order to make a move, it requires a carrier protein, and in the absence of ATP, in the presence of carrier protein, it requires a facilitated diffusion. One such classical example is your glut and aquaporins. So one of the classical example is your blood glucose transporter. Among that, insulin dependent one is your what type of glucose transporter? Glut is insulin dependent. You have to know that. Insulin dependent glucose transporter is GLUT4, which is present in what are the locations of your GLUT4? Adipose tissue, skeletal muscle, and cardiac muscle. Adipose tissue, skeletal muscle, and cardiac muscle. Okay, these are the important structures of your, like insulin dependent glucose transporter, and you have to know in the case of your general physiology people. So we revise the general physiology. Who coined the term homeostasis? Keep your hands on the keyboard. Type faster. Who coined the term homeostasis? Keep your hands on the keyboard and type faster. Who coined the term homeostasis? Walter D. Cannon coined the term homeostasis. Okay, and total body water is how much? Total body water is how much? Percentage of your total body weight? Total body water is how much? Percentage? 60%. Very good. And major cation of your ECF is? Major cation of your ECF is? Major cation of a ECF is? Sodium. Very good. And what type of dye we uses for the measurement of plasma? What type of dye we uses for the measurement of plasma? Very good. Very good. Very good. Evanson radioiodinated albumin. Radioiodinated albumin, not simply radioactive iodine. It's a radioiodinated albumin. Okay, I-25 albumin is the one you have to remember. Evans blue and I-25 albumin. Okay, now speaking about that, we are going on to the physiology. So speaking about the cardiovascular physiology, first we discuss about the action potential curves of your physiology. One is your ventricular muscle, another one is your SA node and the AV node. Ventricular muscle, another one is your SA node and AV node. So since I draw the diagram here, I want you to draw in the side by side, so that I draw over here and you have to draw it in the side by side. So whenever the muscle is not contracting or resting, it will be on the phase 4 people. It will be on the phase 4. Okay, phase 4 is so called as resting membrane potential. Phase 4 is so called as resting membrane potential. Whenever the action potential is arrives, then the sodium influx will happen. So resting membrane potential is somewhat 9 as 90 millivolt people. Resting membrane potential is somewhat minus 90 millivolt, people. And the potential, we have the sodium influx, sudden sodium influx is rushing in. Then what happened to the potential? The potential will start rise, right? So the potential will rise spontaneously from negative to positive up to plus 30. This phase is so called as phase 0. This phase is so called as phase 0 or depolarization phase. This phase is so called as phase 0 or depolarization phase, where we see the potential rising from minus 90 to plus 30 millivolt. Minus 90 to plus 20 or 30 millivolt, people, which interprets P wave and QRS complex on your ECG. And the major ion responsible for this depolarization phase or phase 0 is sodium ions, which is influxed here. And then what happened? Then the muscle has been contracted, then it has to relax. Yes or no? So it will undergo initial repolarization. It will undergo initial repolarization, where you see the phase 1 is so called as initial repolarization phase. Phase 1 is initial repolarization phase. Repolarization phase. Sorry, the thing was very small, so I was writing. Okay, initial repolarization phase. While phase 0 is so called as depolarization phase. Depolarization phase, while the phase 1 is so called as initial repolarization phase. And then you have this phase 2, which is a plateau phase, where there is no change in the potential, and the plateau phase is maintained by potassium efflux and calcium influx. Potassium efflux and calcium influx is happening, which indicates your ST segment in your ECG. And then you have this plateau phase. Below the plateau phase, you have the phase 3, which is a final repolarization phase. Final repolarization phase, where you see the potential drops, where due to the potassium efflux. And phase 4 is again resting membrane potential phase, which indicates the TQ segment of your ECG. Phase 4 is maintained by your sodium potassium ATPase. So how does you have to remember, what are the things you have to remember in this action potential curve, people? So I will give you a small table here. You can write it over here, the small table. Phase 0, you have the 5 phases of your action potential curve. Phase 0, phase 1, phase 2, phase 3, and phase 4. What ions are responsible for phase 0? Sodium influx. And phase 1, potassium efflux. And phase 2, potassium efflux and calcium influx. That's why positive is going out and positive is coming in. That's why there is no changes in the potential. And phase 3, it is a potassium efflux further. And phase 4, it is maintained by sodium potassium ATPase. And what type of ECG indicates? P wave and QRS complex. P wave and QRS is initiated by your phase 0. And phase 1, it is a J point. And phase 2, it is a ST segment. And phase 3, it is a potassium efflux, where it indicates the T wave. And phase 4, it is a TQ segment. You can able to remember it like a curve like me, or you can able to make a table and you can mug up this table. Both are okay, but you have to master these things. These things are quite kind of like a high yield areas you have to know. For the ventricular muscle, remember this entire action potential curve is totally for ventricular muscle. We have the separate one for SA node and AV node. We have the separate one for SA node and AV node, where you see there is a phase 0, which is due to the influx of L-type calcium channel. Very, 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 very important MCQ. L-type calcium channel. Okay. L-type calcium channel, which indicates the phase 0. Okay. And then you have there is no phase 1 and the phase 2 in SA node and the AV node. You directly goes for the phase 3, which is due to potassium efflux. And the phase 4, it is due to the spontaneous diastolic depolarization. which is due to the spontaneous diastolic depolarization. And phase 4 is maintained by three things. Phase 4 is maintained by three things. One is your potassium current, another one is your funny current, another one is your calcium influx. Okay, potassium currents, funny currents, and calcium influx through your L-type channel are the three areas where are the three things that has been using it the SA nodal phase 4. Among that, the funny current is inhibited by a drug called as ivabradine. The funny current is inhibited by the drug called as ivabradine. Very, 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 very important drug we use as clinically in order to use, control the rate in the atrial fibrillation. We use as the IVA node or ivabradine. I mean, technically, ivabradine 5 mg OD we used to write. Okay, in order to maintain or restore the rhythm in the body, we give a IVA node to control the rate. Sometimes the heart rate of the patient would be more than 120, 130, 140, right? That time we give a IVA node 5 mg or maybe up to 10 mg we can give it as a stat dose to, come back to get back the heart rate into 60 or 70. Okay, what is the mechanism of action of the ivabradine? Funny current inhibitor or funny current blocker, which in turn decreases phase 4 of your action potential curve, so that there is no potential rise, there is no firing rate. Okay, so that there is no potential rise and there is no firing rate you will be seeing, and the heart rate will be reduced in that patient. Okay, clear. Now, there are two types of things you have to know in the case of your action potential. One is your refractory period. One is your refractory period. It is classified into two types, effective and relative. Effective refractory period means whenever the conducted action potential is happening and there is no further stimulus can be elicited. Okay, no further stimulus can be elicited. So conducted action potential cannot be elicited when there is a previous one is running. Okay, so till the phase 0 to half of phase 3 is so called as effective refractory period, people. While the relative one, the action potential is happening and next stimulus is coming. In the effective refractory period, the stimulus cannot be elicited. Yes or no? Because already we are running one, please wait, the heart says. But in the case of relative refractory period, a strong stimulus can able to elicit the action potential. Okay, a strong stimulus can able to elicit the action potential. That is your, if relative refractory period is coming somewhere between your phase 3 middle to phase 0. Till the phase 0, you are having this relative refractory period. A strong stimulus can initiate the action potential in the relative refractory period. So far, we have covered the action potential curve, people. So far, we have covered the action potential curve. Okay, next important thing is there are certain important terminologies you have to know. Chronotrophy, dromotrophy, bathymetrophy, and inotrophy and lucitrophy are the 5 important ones you have to know. Chronotrophy, which means related to heart rate, people. Chronotrophy means heart rate, while dromotrophy means cardiac conduction velocity. Okay, cardiac conduction velocity. What is chronotrophy? Heart rate, which relates to the heart rate. Increase in heart rate, that is a positive chronotrophic effect. Decrease in heart rate, that is a negative chronotrophic effect. Okay. Similarly, we are having dromotrophic effect, which is relates to the cardiac conduction velocity. And then you have this bathymetrophic effect, which is due to the cardiac excitability. And then you have this inotrophic effect, which relates to cardiac contractility. And lucitrophy relates to cardiac relaxation. Lucitrophy relates to cardiac relaxation. So 5 things: inotropy, heart rate, and dromotrophy, cardiac conduction velocity; bathymetrophy, cardiac excitability; inotrophy, myocardial contractility; lucitrophy, cardiac relaxation, people. So far 5 things. What are they? Inotrophy means myocardial contractility. Chronotrophy means increase in heart rate, okay, or relates to heart rate. And dromotrophy, cardiac conduction velocity. And then you have this bathymetrophy, cardiac excitability. And lucitrophy, it's a cardiac relaxation. It's a cardiac relaxation, people. So again, we are having this ECG ECG changes, I'd rather go for the, the duration, because rest of the ECG significance, we will study that same in the medicine revision too. So I don't want to insist much there, but I will tell you what are the important things you have to know. Okay, so the duration is pretty important. P wave duration is 0.1 second. Tall P wave is seen in the right atrial enlargement, and wide P wave is seen in the left atrial enlargement. Okay, and QR is complex, 0.8 to 0.1 second, and wide is seen in the bundle branch block as well as in hyperkalemia. Okay, and the T wave 0.2 second, and we have this PR interval and 0.12 to 0.2 seconds, and QT interval 0.35 to 0.4 seconds, and RR interval that should be 0.6 to 1 second, 0.6 to 1 second. And then you have this PR segment and ST segment. So ST segment is increased or depressed in the myocardial infarction, and ST segment is depressed in hypokalemia. Very, 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 very important. Okay, hypokalemia can cause ST segment depression. Depressed ST segment is seen in hypokalemia. Tall T waves is seen in hyperkalemia. Tall T waves is seen in hyperkalemia, while inverted T waves as well as ST segment depression is seen in hypokalemia. Okay, hypokalemia, you will see the inverted as well as decreased inverted T wave as well as decreased ST segment. You may see that in the hypokalemia, while tall T waves, you may see that in the hyperkalemia. Okay, tall T waves, you may see that in the hyperkalemia. So far we have done the ECG changes, action potential, and important terminologies related to the cardiovascular system. Now we are going to talk about the cardiac cycle, people. Now we are going to talk about the cardiac cycle. The cardiac cycle has been taught to you already in several places, and like a lot of people have taught you the cardiac cycle. So what I'm going to talk about here is like, the important things you have to know in terms of cardiac cycle, because if I explain the cardiac cycle with each and every each and every phase of your cardiac cycle, what is the pressure change, what is the heart rate change, what is the volume change, if I explain keep on, it will take at least 1 hour to teach you cardiac cycle. So what we are going to do is, due to the short amount of time, we are going to highlight the important things you have to know about the cardiac cycle that you should not miss. Is that clear? Is that clear? Shall I proceed to the cardiac cycle, people? Okay. Now, speaking about the cardiac cycle, we are having a systole and then we are having a diastole. We separate the cardiac cycle into systole and diastole. So since we are having a systole and diastole portion, atrial systole, ventricular systole, and similarly ventricular diastole and atrial diastole, we can able to divide. Atrial systole, ventricular systole, atrial diastole, and ventricular diastole. So the duration of your atrial systole is 0.12, and duration of your ventricular systole is 0.27, and atrial diastole is out of 0.8, 0.1 goes, they get a 0.7, and 0.27 goes 0.53. Okay, ventricular diastole is 0.53. Okay, atrial systole 0.1, atrial diastole 0.7, ventricular systole 0.27, and ventricular diastole 0.53. Okay, so we are not going to discuss anything about the atria here. So ventricular systole and ventricular diastole. So what are the phases in the ventricular systole? What are the phases in the ventricular diastole? So ventricular systole is having an isovolumetric contraction, rapid ejection, and a slow ejection will be seen in the ventricular systole. Okay, what are the things? Isovolumetric contraction, rapid ejection, slow ejection will be seen in the ventricular systole, where you see the S1 will be heard in isovolumetric contraction, and isovolumetric contraction ends by opening of aorta. Only thing you have to know. So what phase you hear the S1? Isovolumetric contraction. What are the phases of ventricular systole? Isovolumetric contraction, rapid ejection, slow ejection. So isovolumetric contraction ends by opening of aorta. Then ventricular diastole, we are having a 5 phases. protodiastole. We are having a 5 phases: protodiastole, isovolumetric relaxation, rapid filling, slow filling, atrial contraction. Rapid filling, slow filling, atrial contraction. These are the 5 phases you may see. Among that 5 phase, S2 will be heard in protodiastole. Among that 5 phase, S2 will be heard in protodiastole, and isovolumetric relaxation ends by opening of AV valve. Isovolumetric relaxation ends by opening of AV valve. Then you have the rapid filling and the slow filling, where you see the rapid filling, you see the S3, and atrial contraction, you will see the S4. Atrial contraction, you will see the S4. So what are the things you have to remember in terms of cardiac cycle is atrial systole, atrial diastole, duration, atrial systole, atrial diastole duration, and ventricular systole, ventricular diastole duration. Ventricular systole and ventricular diastole duration. So speaking about these things, we know that one heartbeat is 0.8 seconds. So for atrial systole, 0.1 second, and atrial diastole should be 0.7 seconds. And ventricular systole should be 0.27 seconds. So your ventricular diastole should be 0.53 seconds. 0.53 seconds. S1 will be heard in isovolumetric contraction. S2 will be heard in protodiastole. Protodiastole. S3 will be heard in rapid filling. Rapid filling. And S4 will be heard in atrial contraction. S4 will be heard in atrial contraction. And what phase is also called as diastasis phase? That is slow filling phase. Diastasis phase is also known as slow filling phase. You have to know that. Only this line you have to remember. Only this line and table you have to remember. So don't, this IVC is isovolumetric contraction. Don't write it as isovolumetric contraction. Don't write it as inferior vena cava. Okay, you have to remember. This is an isovolumetric contraction, not the inferior vena cava. Okay, protodiastole. For example, S2, if protodiastole is not given, then isovolumetric relaxation. Then isovolumetric relaxation is a second preferable option. Okay, if the protodiastole is not given to you. If the protodiastole is not given to you. Okay, clear? So with this, we pass for a break. So we take a 10 minutes of break and see you all by 6:10. So we proceed with the second session of your physiology. Okay. So for the speed and pace is okay, or do you want me to go a little bit slow? A little bit faster is okay for you people. Is it okay? Or you want me to slow down a bit, or you want me to go fast a bit? You can say me, no problem. I can go a little bit faster. Can I go a little bit faster? Yes. Or you feel it is fast? You want me to slow down a bit, or you want me to go faster? Okay, go faster. Then we proceed with a little bit of faster things. No problem. Okay, see you all by 6:10, and the classes will go till 7:30. Okay, classes will go till 7:30. Okay. Shall we resume, people? So resuming the sessions. Yeah, so I heard like there was need a little bit of revision. Yeah, we will do once the systems has been completed. Each system we will do one small revision. For each and every system we will do one small revision. Okay, for 5 minutes. No problem. No problem. Then you are having a JVP. So speaking about the JVP waveforms, we will do the JVP waveforms now. JVP waveforms is also one of the high yield area, people. JVP waveforms is also one of the high yield area that you should not miss. Okay, let me put this here. So we're having this JVP waveform. So what are the waves we may see in the JVP? So we may see the A wave, and then followed by C wave, followed by X descent, followed by V wave, followed by Y descent. So what are the waves we can see here? We can see A wave, C wave, X descent, V wave, and Y descent. Okay, A wave, C wave, X descent, V wave, and Y descent are the 5 wave patterns you may see in the JVP wave. And the JVP wave, so A wave is indicating the right atrial contraction, people. A wave is indicating what? Right atrial contraction, and a large A wave is seen in right atrial myxoma. Very, very important MCQ. The large A wave is seen in pulmonary hypertension and right atrial myxoma. Both are important. And absent A wave is seen in AF and Epstein anomaly. And Canon A wave is seen in AB dissociation. All the A wave abnormalities are pretty important. Large A wave, tricuspid stenosis or pulmonary stenosis, and pulmonary hypertension, and then you have this right atrial myxoma, you may see the large A wave. And the Canon A wave is seen in AV dissociation, which is in the congenital congestive heart block, and absent A wave is seen in Epstein anomaly. Very, 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 very important MCQ that you should not miss, people. Okay, then you have the C wave, bulging of your tricuspid valve into the right atrium. So technically, it indicates the isovolumetric contraction phase. So C wave technically indicates isovolumetric contraction phase in the cardiac cycle. And apart from that, you have the X descent due to the decrease in the right atrial pressure due to atrial relaxation. And technically prominent X descent is seen in constrictive pericarditis, and the blurred X descent is seen in tricuspid regurgitation. Blurred X descent is seen in tricuspid regurgitation. Then you have the Y descent. So Y descent is due to a rapid emptying of right atrium, and mostly we can correlate with the S3. And the prominent Y descent is seen in tricuspid regurgitation and constrictive pericarditis, and blurred Y descent is seen in tricuspid stenosis or right atrial myxoma. Right atrial myxoma. Apart from that, you have to know one important sign called as the small sign. What is this small sign or small sign, however you pronounce it? Whenever you see the inspiration, there is an elevated JVP. Elevated JVP during the inspiration is so called as the small sign, and small sign is seen in constrictive pericarditis and massive pulmonary embolism and RV infarct and restrictive cardiomyopathy are the 4 scenarios you may see that there is a small sign. So you see the elevated JVP during the inspiration, you may see this small sign, and which is seen in constrictive pericarditis, massive pulmonary embolism, RV infarct, and restrictive cardiomyopathy. RV infarct and restrictive cardiomyopathy, all the 4 scenarios you may see the small sign. And apart from that, you may see the abnormalities of the JVP are quite really important. You should know the JVP waveforms, people. You should know that JVP waveform. You should not miss it. Apart from that, this is kind of like a pressure volume loop. This is point A, B, C, and D, where you see the mitral valve closes. And when the mitral valve closes, isovolumetric contraction will begin, while the pressure remains the same, volume remains the same, and pressure start increasing from the atrial pressure to the aortic pressure. Once it reaches the aortic pressure, aortic valve will open, and then you have the rapid ejection and the slow ejection. And then once it has reached the systolic BP, you may have the aortic valve closes, and then from the diastolic BP, it may pass down, and the isovolumetric relaxation phase will begin. And then you have this mitral valve open whenever the pressure drops below the atrial pressure. Okay, so we have the point A, point B, point C, and point D. Point A indicates that there is a mitral valve opening. Point B indicates aortic valve opening, and point C, aortic valve closure, and mitral valve closure, aortic valve open, aortic valve closes, and mitral valve open. Point D. Okay, so these are the variable forms you have to remember. Just remember the normal pattern. You know the normal pattern is somewhere mitral valve open, blood goes into the ventricle, and the mitral valve closes, ventricular pressure increases, then aortic valve open, blood flows into the aorta, and then you have this aortic valve closure, and then blood will be filling into the aorta, and then isovolumetric relaxation. Pressure drops below the atrium. You may have this mitral valve open again to fill up the blood. You know that this is a normal curve. A, B, C, and D. Closure of mitral valve, opening of aortic valve, and the closure of aortic valve and opening of mitral valve. Okay, this is the thing you know. And what are the abnormal pattern? For mitral stenosis, you may have this type of curve. You may have this type of curve in mitral stenosis. And for aortic stenosis, you may have the pressure increases with the volume decreases. And then you have the mitral regurgitation, pressure decreases with the volume increases. And you have this, like aortic regurgitation, both will increase. Pressure and volume, both increases in aortic regurgitation. So these are the abnormal curve you have to remember. Maybe they ask you in a picture-based question in physiology, but that is very rare. That is quite a rare of abnormal pressure volume loop type of questions. Okay, next, determinant of cardiac output. Cardiac output can be determined by 4 methods. Cardiac output is calculated generally with the heart rate and stroke volume. And the heart rate is directly proportional to cardiac output. And the stroke volume depends on 3 factors, people. One is the preload, another one is the afterload, another one is a myocardial contractility. So stroke volume depends on 3 factors: preload, afterload, myocardial contractility. Cardiac output is directly proportional to preload, while inversely proportional to afterload, and directly proportional to contractility. So whenever contractility increases, stroke volume increases. Stroke volume increases, cardiac output increases. Whenever afterload increases, cardiac output decreases. Similarly, whenever preload increases, and automatically you may see that there is an increase in the stroke volume, increase in the cardiac output. Okay, fine. Then apart from that, along with that, heart rate into stroke volume is one formula to calculate a cardiac output. Apart from that, you have a direct fixed method, which is a gold standard method. We uses a O2 consumption with the atrium and vein, arteries and veins. AV-O2 difference will be coming in the denominator, and O2 consumption will come into the numerator. Okay, so by this we can able to calculate the cardiac output. And apart from that, indicator dilution method, we used to based on the Stewart-Hamilton principle, where the amount of dye injected will be on the numerator and the concentration of indicator on the denominator. Concentration of indicator on the denominator, so that we can able to calculate the cardiac output. Then thermodilution method, where the indicator is similar to the indicator dilution method, but the indicator we use is a normal saline. So 4 methods we calculate cardiac output, people. What are they? Cardiac output is the normal Jarek formula, heart rate into stroke volume. Fixed method, O2 consumption divided by arterial venous O2 difference. And the indicator dilution method, also known as Stewart-Hamilton method. How are we producing it? Amount of indicator dye injected divided by concentration of indicator. Then thermodilution method, similar to indicator dilution method. Okay, clear about that? Okay, now what are the changes you can able to get where you can able to see in the cardiac output apart from this normal things? Okay, so what are the normal things that can produce such changes in the cardiac output? Increase in cardiac output, anxiety, eating, exercise, environment, temperature, pregnancy, and epinephrine can rises your cardiac output, while standing from lying and heart diseases can decreases your cardiac output. Remember, sleep have no change in cardiac output. Very, 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 very important MCQ. Sleep has no change in cardiac output. Sleep has no change in cardiac output. And then we have this ejection fraction, systolic volume, stroke volume divided by end diastolic volume into 100% is the ejection fraction. What is the normal ejection fraction, people? What is the normal ejection fraction? 55 to 65%. Depending upon the individual, it may varies. Okay. Depending upon the individual, it may varies. Okay. Then regional distribution of cardiac output. The liver will receive the maximum. Next highest receiver is your kidney, and then followed by brain, followed by your skeletal muscle, followed by your skin, followed by your skeletal muscle, and then the skin. So highest receiver is brain, 27.8. Second highest receiver is kidney, 23. And then you have the brain, 13, and the skeletal muscle, 15. And then you have the skin, 8.6. Okay, and then skin, you have a 8.6. Okay, so this is all about the cardiac output, people. This is all about the cardiac output. Then, so how do you calculate the mean arterial pressure? This formula of calculating the mean arterial pressure was asked nearly 5 to 6 FMGE people. You have to remember that. How do you remember mean arterial pressure? Diastolic blood pressure plus 1/3 systolic blood pressure minus diastolic blood pressure. Okay, diastolic blood pressure plus 1/3 systolic blood pressure minus diastolic blood pressure is the formula we uses. Or we can put it in this way. Diastolic blood pressure, or don't consider it like a division. Okay, I will rather write it here in the bottom. Diastolic blood pressure plus 1/3 pulse pressure we can write. Okay, 1/3 pulse pressure we can write. So systolic minus diastolic blood pressure is your pulse pressure. So diastolic plus 1/3 pulse pressure. So that is 80 plus 1/3 into 1/3 into 40, which gives you 80 plus 13.33, which in turn gives you 93.33. What is a normal mean arterial pressure? What is a normal mean arterial pressure? Which is 93.33 mm of Hg, which is 93.33 mm of Hg. Whatever the values you closest you have seen, you are seeing there, you may able to calculate there itself. Okay. So diastolic blood pressure plus 1/3 pulse pressure is the thing you have to remember in the case of your formula for mean arterial pressure. Okay, quite an easy one. Then regulation of your cardiovascular system. So it is mainly regulated by your medulla oblongata. So we used to call that as a medullary control of your cardiovascular system. So what are the medullary controls we are having to regulate your cardiovascular system? One is your vasomotor center. One is your vasomotor center. Another one is your medullary parasympathetic center. And another one is your baroreflex relay center. Baroreflex relay center. So this baroreflex relay center is mediated by a nucleus tractus solitarius. Solitary tract nucleus will able to control your baroreflex relay center. Okay, and then for a medullary parasympathetic, it is done by your nucleus ambiguous, where it decreases heart rate and decreases force of contraction. Where it decreases heart rate and decreases the force of contraction. While the vasomotor center is controlled by your rostral ventrolateral medulla, RVLM. Rostral ventrolateral medulla. Stimulation of this vasomotor center, that is your RVLM, will cause arteriolar constriction, vasoconstriction, and positive chronotrophic and inotropic effect. And positive chronotrophic and inotropic effect will be seen in the regulation of your cardiovascular system. Okay, fine. What is a chronotrophic and what is inotropic, people? What is a chronotrophic and what is a inotropic? Stimulation of your RVLM will cause a positive chronotrophic and a positive inotropic. What is chronotrophic? What is inotropic? What is meant by chronotrophic and what is meant by inotrophic? What is meant by chronotrophic and what is meant by inotrophic? Which one is related to heart rate, chronotrophic or inotrophic? Okay, chrono, it's heart rate, and ino, chrono, it's a heart rate, and ino, it's a myocardial contractility. I know it's a myocardial contractility. Okay, so you have to remember that. And then how does your BP is regulated? BP is regulated for long-term and short-term regulation. We talk about the short-term regulation. One is your baroreflex, another one is your chemoreflex, another one is your CNS ischemic response. CNS ischemic response is mediated by Cushing reflex. CNS ischemic response is mediated by Cushing reflex. And chemoreflex is lack of oxygen, and it in turn stimulates your chemoreceptor, and stimulation of chemoreceptor produces vasoconstriction and a tachycardia, and thereby raising the BP. Okay, while the baroreceptor increase in the BP, distension of your baroreceptor, increase in the firing rate of your cranial nerve 9 and 10, and which excites your, like a neurotransmitter, and intense stimulates your vagus nerve, and intense stimulates your caudal ventrolateral medulla, and stimulated caudal ventrolateral medulla intense suppresses your rostral ventrolateral medulla. Intense suppresses your rostral ventrolateral medulla, so that you can able to see the decrease in the BP. Okay, whenever the BP is raised, baroreceptors are activated. There will be an increase in the firing rate of cranial nerve 9 and 10, which in turn stimulates the cranial nerve vagal neuron, as well as which in turn stimulates your CBLM, thereby inhibiting your RBLM. So this is how your baroreflex mechanism is working. Okay. So apart from that, these are the important things you have to know in terms of your CVS. So apart from that, there are certain vasoconstrictor and dilators are there. Pretty straight mug up point, people. Urotensin 2, endothelin, vasopressin, angiotensin 2, norepinephrine are constrictors, while nitric oxide, CGRP, prostacyclin, histamine, carbon monoxide, substance P, epinephrine in the skeletal muscle and liver are the vasodilators. Okay, these are the vasodilators you have to remember. Vasoconstrictors and important vasoconstriction and vasodilators. That you have the PDF, you have to contact with the DMA people for regarding the PDF release. Okay, you can contact them regarding the further things. Okay, so far we have done with the CVS. So speaking about the general and the CVS, shall we revise the CVS, people? Shall we revise the CVS? 5 minutes, very sharp. 5 minutes, very sharp. You have to answer most of the question. Homeostasis was coined by. The term homeostasis was coined by Walter D. Cannon. Action potential is an example of what type of control system? Action potential is an example of what type of control system? Action potential is an example of what type of control system? It's a positive feedback. Deuterium is a dye used to measure total body water. Inulin is a dye we measure ECF. Evans blue is a dye we measure plasma. Major cation in the ECF, sodium. Major cation in the ICF, potassium. Major anion in the ICF is phosphate. Major anion in the ECF is chloride. And membrane transport, speaking about that, sodium potassium ATPase is a classical example of primary active transport. GLUT is a classical example of facilitated diffusion. SGLT is a classical example of secondary active transport. Then, speaking about the cardiovascular physiology. So, phase 0 of an action potential curve of ventricular muscle fiber is totally depends on sodium influx, while phase 1, potassium efflux. Phase 2, plateau phase, potassium efflux and calcium influx. Phase 3, potassium efflux. Phase 4, sodium potassium ATPase. While P wave and QRS complex on the ECG depends on or relates to what phase in ventricular action potential. That is your phase 0, J point, phase 1, ST segment, phase 2, T wave, phase 3, TQ segment, phase 4. While the phase 0 of SA node and the AV node depends on L-type calcium channel. L-type calcium channel or calcium influx. Ivabradine is a drug which blocks funny current. Ivabradine is a drug which blocks funny current. Phase 0 to half of phase 3 is what type of refractory period? Effective. And phase 3, half of the phase 3 to phase 0, relative. Chronotrophy, heart rate. Dromotrophy, cardiac conduction velocity. Backmotrophy, cardiac excitability. Ionotrophy, myocardial contractility. Lusitrophy, cardiac relaxation. Duration of ECG wave. 0.1 second is P wave. QRS complex, it is 0.882.1 second. T wave, it is 0.2 second. PR interval, it is 0.1 to 2.2 second. QT interval, it is 0.35 to 0.43 second. And RR interval, it is 0.6 to 1 second. And decreased ST segment or ST segment depression is seen in hypokalemia and myocardial infarction. Tall T waves are seen in hyperkalemia and myocardial infarction, while depressed ST segment is seen in hypokalemia. So hypokalemia, we see a depressed ST segment, and in hyperkalemia, we see there is a tall T wave. There is a tall T wave. Okay, so these are the important things you have to remember in terms of ECG. Now, cardiac cycle, duration of atrial systole, it is 0.1 second. Ventricular systole, it is 0.27 seconds. Atrial diastole, it is atrial diastole, it is 0.7 seconds. And ventricular diastole, it is 0.53 seconds. S1 is heard in isovolumetric contraction. Protodiastole is heard in in a protodiastole you will see S2 sound. S3 will be heard in rapid filling. S4 will be heard in atrial contraction. While diastasis phase is also known as slow filling phase. Canon A wave in the JVP is seen in AV dissociation, while large A wave is seen in pulmonary hypertension and right atrial myxoma. Absent A wave is seen in AF and Epstein anomaly. A wave indicates right atrial contraction. Kussmaul sign is seen in constrictive pericarditis, massive pulmonary embolism, RV infarct, and restriction cardiomyopathy. And prominent Y descent is seen in constrictive pericarditis and tricuspid regurgitation, while you may see the prominent X descent in the constrictive pericarditis. And C wave on the JVP indicates isovolumetric contraction. Isovolumetric contraction. Formula to calculate cardiac output, stroke volume into heart rate. And stroke volume depends on three factors: preload, afterload, myocardial contractility. Among that, afterload is inversely proportional to cardiac output. Does sleep cause any change in cardiac output? No, it never. Liver receives maximum amount of cardiac output. And second most is kidney, third most is skeletal muscle, fourth most is brain, and fifth most is skin. And last is your heart. And formula to calculate MAP is diastolic blood pressure plus 1/3 systolic blood pressure minus diastolic blood pressure. Formula to calculate ejection fraction is stroke volume divided by end diastolic volume into 100%. So we have done the revision of your cardiovascular system. Shall we move on to the next system? Which is your GI system, which is a high yield area that you have to remember. So we will first finish the high yield areas and then we go for the low yield areas. Okay. So the next system we are going to talk about is your GI physiology. So I rather remember GI physiology in a very short term portion. Like I used to divide the entire GI into secretions and motilities. Okay, I used to remember the entire GI physiology into secretion and motility people. So what type of secretion, which is seen in the salivary, gastric, intestinal, and the colon, and similarly motility, what type of thing you will do? You will finish the GI physiology. Okay, first thing we will discuss the GI secretion, salivary gland. So you are having a salivary gland secretion comes from three major one, and the per day salivary gland secretion is about 1,500 ml. Among that, 70% is coming from the submandibular and parotid and sublingual. Submandibular, parotid, and sublingual gland. So 70% comes from submandibular, 25% comes from the parotid, and 5% comes from the sublingual. Okay, among that, parotid gland is a purely serous one. Parotid glands is a purely serous one. And emptying ducts are pretty important in this case. Submandibular duct empties into Wharton's duct, and the parotid gland empties into Stenson's duct, and the sublingual gland empties into duct of Ravinus. Sublingual gland empties into duct of Ravinus. So Wharton, Stenson's, and duct of Ravinus are the important thing you have to remember. Then, what is the enzymes you may see in the case of your salivary gland? Enzymes are salivary amylase and salivary lipase, or lingual amylase and lingual lipase, or however you call it. And the functional unit of your salivary gland is salvian, which contain acinar cells and duct epithelium. And regulation is mediated by inferior and superior salivary nucleus. Inferior and superior salivary nucleus. So inferior salivary nucleus will play a contributory role in terms of your parotid gland, while the superior salivary nucleus will play a contributory role in terms of your submandibular and sublingual gland. So inferior salivary nucleus regulates parotid, superior salivary nucleus regulates submandibular and sublingual. So we had a salivary gland, three glands, submandibular, parotid, and sublingual. Among that, which one is receiving the maximum secretion? Among that, which one is receiving the maximum secretion, people? Among that, which one is receiving the maximum secretion? Faster, faster, people. Keep your hands on keyboard and type faster. Which one is having a maximum secretion out of this three salivary gland? Submandibular gland. Okay, out of that, submandibular gland. Okay, submandibular gland empties into Wharton's duct. Very good. Parotid gland empties into Stenson's duct. Sublingual gland empties into, very good, duct of Ravinus. Okay, so parotid gland is regulated by inferior salivary nucleus, while submandibular and sublingual is regulated by your superior salivary nucleus. Okay, now from the saliva we go to the gastric acid secretion. from the salivary secretion, we goes to the gastric acid secretion. So speaking about the gastric acid secretion, so first one, consider this is your gastric parietal cell. Consider this is your gastric parietal cell. In that gastric parietal cell, we have the water and the carbon dioxide combined. I'll rather use a different color. We have the water and carbon dioxide which is combined, and then which has been broken down into bicarbonate and H plus via this carbonic anhydrase enzyme. Via this carbonic anhydrase enzyme. Speaking about this carbonic anhydrase, this bicarbonate will break the it will combine the water and carbon dioxide and splits into H plus and HCO3 minus. And this bicarbonate will move out into the blood. This bicarbonate will move out into the blood for the exchange of chloride. And similarly, this chloride influx will move on to the gastric lumen. And then this H plus will be exchanged for your dietary potassium. This H plus will be exchanged for your dietary potassium, mediated by the exchange of H plus with the potassium is mediated by your H plus K plus ATPase pump, also known as proton pump. Rather, right? Proton pump. Okay. Because it is pumping the proton out of the gastric parietal cell, which is a H plus 1. Okay. So H plus came and Cl minus came. They both combine to form a HCl. This is how your gastric acid is forming. Okay, your gastric acid is regulated by 3 substances, people. 3 type of regulation is seen in the gastric acid secretion. One is your neuronal one, mediates by your vagus nerve, where through the M3 receptor, and a hormonal one, you have the gastrin one. Gastrin is a hormone which which stimulates your gastric acid secretion, and paracrinal secretion is done by your histamine through the H2 receptor. That's why we give drugs like ranitidine, famotidine, loxetidine, cloxetidine. All the tidines will be your H2 receptor blocker. So in turn will control your gastric acid secretion. And similarly, you have the gastrin and the vagus M3 receptor antagonist like a pyranzipine, telanzipine, M1 and M3 receptor antagonist we can give for the gastric acid suppression. Okay. Because this thing can stimulate the vagus nerve, and vagus nerve increases your gastric acid secretion. Okay, apart from that, what are the things that can able to decreases your gastric acid secretion? Somatostatin, gastrointestinal polypeptide, GIP, secretin, CCKs, and prostaglandins. So far we are having this 3. Neuronal, hormonal, and paracrinal regulation. So vagus nerve stimulates gastric acid secretion through M3 receptor. Gastrin secretes the gastric acid secretion, and histamine secretes your gastric acid secretion. And apart from that, what are the substances which inhibits your gastric acid secretion? Which is somatostatin, GIP, secretin, CCK, and PG, prostaglandins. Okay, now what are the phases of your gastric acid secretion, and what phase it secretes more? It secretes more on the gastric phase, which is 60% of your gastric acid is contributed through the gastric phase, where you see more and more amount of gastric acid secretion. The 3 phases are cephalic, gastric, and intestinal phase. Okay, fine. We have done the gastric acid secretion and we have done the salivary gland secretion. Okay, then we are having a pancreatic secretion. So pancreatic secretion, similar to that of your gastric acid secretion. Again, it will be acidic. So carbonic anhydrase will move on to the bicarbonate H plus, and the H plus will be here. It is exchanged for sodium instead of a potassium in the gastric acid. It exchanges for the sodium. And inactive form of enzymes in the pancreas is so called as zymogens. Very, 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 very important MCQ. They may ask you, what are zymogen? Inactive form of enzymes in the pancreas is so called as zymogen. And regulations is mediated by secretin and cholecystokinin. Secretin and cholecystokinin are the 2 regulators of your pancreatic secretion. Okay, that you have to remember. And now speaking about the biliary secretion, there are 2 types. One is your bile acid and bile salt. So bile acid Bile acid secretion is, we will study that in the biochemistry. That's why I didn't mention it here. All that cholic acid to chenodeoxycholic acid, blah, blah, blah. Those things I didn't add it here because we study that in the biochemistry, tomorrow's session. Okay. But you have to know, remember one thing, that rate limiting step is 7-alpha hydroxylase, people. Rate limiting step for the bile acid secretion is 7-alpha hydroxylase. While bile salt, it is a conjugated bile acid which combines with sodium and potassium ions. Okay, will combines with sodium and potassium ion. And regulation of bile secretion is done by cholecystokinin, secretin, and vagus nerve. Cholecystokinin, secretin, and vagus nerve. So biliary secretion done, pancreatic secretion is done, and gastric secretion is done, and then you have the salivary secretion done. The last is your intestinal secretion. Once the intestinal secretion done, we covered up all the intestinal, we covered up all the secretions of your GI tract, we revise it. Okay, small intestine is also known as succus entericus, which is secreted by cells in the crypt of your Lieberkühn. Very, very important MCQs. Succus entericus is secreted by the cells in the crypts of Lieberkühn. Okay, and for large intestine, which is secreted by the mucus secretion, mostly it is stimulated by your parasympathetic nervous system, nothing much. Okay, mostly it is a parasympathetic nervous system stimulation. So this is all about your secretion, people. Salivary gland, gastric secretion, and your pancreatic secretion, and your biliary secretion, and your intestinal secretion, and your intestinal secretion. Let me revise it very fast away. Salivary secretion. The major salivary secretion comes from where? Major salivary secretion comes from where? Submandibular gland. Very good. And functional unit of salivary gland is? Functional unit of salivary gland is salvion. Gastric regulation, stimulation of gastric acid is done by vagus nerve, gastrin, histamine. While inhibition of gastric acid secretion is done by somatostatin, GIP, secretin, CCK, and prostaglandins. Gastric acid secretion is very high in what phase of secretion? Gastric phase. What is the pump which pushes the hydrogen ions or protons out of the gastric parietal cell? Proton pump or H plus K plus ATPase. H plus K plus ATPase. Now, apart from that secretion, pancreatic secretion, mechanism of pancreatic secretion similar to gastric acid secretion, except instead of potassium, sodium will be exchanged for H plus. Regulation, secretin and cholecystokinin. Inactive form of enzymes in pancreas is also known as inactive form of enzymes in pancreas is also known as what? Is also known as zymogens. Is also known as zymogens. Rate limiting enzyme of bile acid synthesis is 7-alpha hydroxylase. 7-alpha hydroxylase. Okay. Now, succus entericus is secreted in cells of crypts of Lieberkühn. Crypts of Lieberkühn. Mucus secretion on the large intestine is stimulated by mucus secretion on the large intestine is stimulated by parasympathetic nervous system. Parasympathetic nervous system. Very, very important. So with this, we have completed the GA secretions. We are moving on to the GA motility. So gastric emptying. So first thing we are going to talk about is your gastric motility. Gastric emptying is stimulated by or increased by gastrin and food volume, and decreased by fat, carbohydrates, or acid in the duodenum, and hyperosmolarity of duodenum, and cholecystokinin and peptide double Y bond. Peptide double Y can able to decrease your gastric motility. Sorry, gastric emptying, I rather say. Then intestinal motility, we can able to divide the intestinal motility into two types. Namely, we can divide the intestinal motility into two types, namely small intestinal motility and large intestinal motility. So small intestinal motility, mixing or segmentation contractions, you may see mixing or segmentation contractions, you may see, and then there the propulsion of the food will be there. So propulsive contraction followed by tonic contraction. Small intestinal motility is mediated by three main types of contraction: mixing or segmentation of segment contraction, propulsive contraction, tonic contraction. Propulsive contraction and tonic contraction. Apart from that, you have the large intestine, mixing movement also known as hastration. Mixing movement, mixing movements also known as hastration, where it moves a bulky food, and then followed by the defecation, excretion of your fecal material, and internal anal sphincter and external anal sphincter plays a role here. So internal is involuntary while external is voluntary. Okay, so speaking about the gastric motility, the major type of questions you may expect is, one is your peristalsis, which you may see in the esophagus. Okay, primary peristalsis and the secondary peristalsis. So stretching of the foot is a primary stimulus for your peristalsis, and then it releases certain substance like a serotonin, substance P and acetylcholine, and then there you may see the stimulation of myenteric plexus and movement of bolus. Okay, so you have the primary, secondary, and the tertiary peristalsis. So type of peristalsis may be asked in the GI pathology, as well as it may be asked in the GI surgery also. Okay, esophagus. Apart from that, you have this migratory motor complex, and there are certain reflexes they may ask you. There are reflexes they may ask you. We will discuss the reflexes here. The first reflex is your defecating reflex. Whenever feces is there, your rectum will undergo distension, and from the rectal distension, you may see the transmission of your afferent impulses to your sacral spinal segment, and reflex of your parasympathetic nervous system will discharge, and then you will see the relaxation of internal sphincter, and then relaxation of external sphincter, and then you see the defecation. When it relaxes the internal sphincter, that's the time you see the urge, and your rectal pressure will be raised. So you want to go to the toilet, and you have to, defecate all the excretors. Then next is the gastrocolic reflex, which is kind of like whenever you eat too much of food. When you eat too much of food, your distension of stomach will be happening. Contraction of rectum will in turn causes a defecation. When you eat too much food, you feel defecation, or you feel the sensation of defecation. That is so called as gastrocolic reflex. Gastrocolic reflex. These are the two important reflexes you may see. Apart from that, you may see the this cells and the secreting hormones. This is the place where you expect most of the question, people. This is the place where you expect most of the question. So these two tables you should not miss. These two tables are kind of like 5-star rated tables that you should never miss a single word. You have to remember, because if they want to ask you a question in GA physiology, this is one of their choice. Okay, so G cells will secrete gastrin, I cells will secrete cholecystokinin, S cells will secrete secretin, K cells or kappa cells will secrete GIP, and D cells will secrete somatostatin, and more cells will secrete motility. Apart from that, you have the ghrelin. Ghrelin will stimulate the GH secretion, people. Gastrin and cholecystokinin and secretin, you already know. All the secretions will be stimulated. For example, gastrin will secrete a gastric acid secretion, and it will also causes the it will also produces the like a growth of your gastric mucosa. And cholecystokinin, we studied that in the regulation in pancreatic secretion. We studied it can decreases your gastric acid secretion. It can able to increase your bile acid secretion also. Yes or no? In the regulation of your biliary system and the pancreatic system, we have seen. Secretin also does the same function. And then you have the GIP, which simulate your insulin, and somatostatin, which suppresses your gastrin, VIP, GIP, secretin, and motilin, and it will also suppresses your pancreatic secretion. So somatostatin is technically a inhibitory enzyme here. Somatostatin is technically a inhibitory substance here, which is secreted by your D cells, and motilin will stimulate the motility, and the ghrelin will stimulate the GH secretion. So every cells, their hormones, their functions are kind of like 5-star. So, so go after me. G cell, gastrin. What type of function it does? Stimulates gastric acid production and stimulates growth of mucosa of your GA tract. I cells, cholecystokinin. Stimulates pancreatic enzyme, contraction of gallbladders, suppression of gastric enzyme, and stimulation or elevation of your EK synthesis. Then secretin, increase in the secretion of bicarbonate in the pancreas, biliary tract, and gastric acid secretion. Then you have the GIP, stimulates insulin secretion. Then you have the somatostatin, which suppresses gastrin, VIP, GIP, secretin, and motilin. And it also suppresses the pancreatic secretion. Then motilin, motility, ghrelin, growth hormone. Ghrelin, growth hormone. So next, I rather move the digestion here. So carbohydrate on the mouth, it will be digested by salivary amylase, or also known as kyelin. If you are seeing any of this name, you can able to choose. And pancreatic amylase, and intestine disaccharidases. So duodenum, it gets absorbed. Lipid, all the lipases on the respective location and get absorbed in the intestine. And protein, pepsin in the stomach, trypsin in the pancreas, and all peptidases in the intestine. Vitamin B12, location of absorption is terminal ileum. Very, 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 very important. Especially when you are reading the anemia, pernicious anemia, this location of vitamin B12 absorption is very, very important. Okay, and then iron, it is duodenum. Iron, it is duodenum. Now, these are the area you have to remember in case of your digestion and absorption of nutrients, and you have to remember the cells and the secreting hormones. You have to remember these 2 tables till the end of your FMGE examination. So there are certain things, you open the page right before in the car and you read something that will come to the exam. This is one among the pages you have to read, people. This is one among the page you have to read right before the exam, or you may sit in the car, you look for things to know whether the question may come or not. One among that page is this page, you have to mark it. Okay, clear about that? Clear about it? Now, moving on to the next high yield area. So we have done the CVS, we have done the what do we call it? We have done this gastrointestinal physiology, and we have done this what do we call it? We have done this general physiology. Now we are going to talk about the neurophysiology. Okay, the next high yield area of neurophysiology we are going to talk about. So in the neurophysiology, the first one is your nerve physiology. So you're going to talk about the structure of neuron. You already knew the structure of neuron, where the cell body covered by the numerous projections and intent covered by one single large projection called as axon. So cell body and axon, while the smaller projections are called as dendrites. And dendrites, all the action potential will combine at the axonal hillock. So you see the summation potential at the axonal hillock. You see the summation potential at the axonal hillock. So wherever the action potential from the dendrite comes, it's summated at the axonal hillock and then generate one single action potential and passes down to the axon. While axon, does the action potential travels continuously? No, it travels in a slow pattern. In order to increase the speed, we need to insulate the wire. Yes or no? That insulation is done by myelin sheath. So myelin sheath in CNS is formed by oligodendrocytes, and in PNS it is formed by Schwann cell. Is the myelin sheath is continuous? No, it's not continuous. It is separated by the nodes of Ranvier. It is separated by the nodes of Ranvier, and the conduction occurs through the nodes of Ranvier is known as saltatory conduction. Saltatory conduction. And axon of one neuron will combine with or connected with dendrite of another neuron via the synapse. Via the synapse. So axon of first neuron will release the neurotransmitter in the synapse, and dendrite of second neuron will respond to that accordingly. So what type of neurotransmitter it can release? It can release either excitatory or inhibitory. It can release either excitatory or inhibitory neurotransmitter. Vitamin A is a fat-soluble vitamin. So this vitamin A can be absorbed along with the lipids. ADEK goes along with the lipids in the form of chylomicron. We discussed that in the tomorrow's session. Don't worry. Okay, we will cover the vitamin A in the vitamin A section, digestion and absorption of the lipids. Okay, lipoprotein metabolism, we covered that. Okay, release of neurotransmitter, we have the excitatory and inhibitory. So excitatory neurotransmitter, major excitatory neurotransmitter in the CNS is your glutamate, and your PNS, it is your acetylcholine. And then a major inhibitory neurotransmitter in CNS, it is GABA, and PNS, it is GABA or glycine. Okay, excitatory neurotransmitter has been released or inhibitory neurotransmitter has been released. They go and bind with the postsynaptic receptors. They goes and binds with the postsynaptic receptor and creates a postsynaptic receptors are the voltage gated ion channel receptor. So it may create the postsynaptic potential. For example, if the neurotransmitter is excitatory, then you may get the influx of sodium ions. Then there is a generation of EPSP. Similarly, if there is an inhibitory neurotransmitter is happening, then you may have the influx of chloride ion. Then there is a generation of IPSP. This is how the connection between one neuron to another neuron is working, people. This is how the connection between one neuron to another neuron is working. Then what are the types of nerve fibers we are having? What are the types of nerve fiber you are having? We are having a variety of nerve fibers which has been classified under the special type of classification called as Erlanger and gases classification. Erlanger's and gases classification. Quite an important classification that you have to remember. Okay, so the very important thing you have to remember is the slowest type is type C. Slowest type is type C. And the one which carries proprioception is your A alpha, and alpha motor neuron is I alpha, and gamma motor neuron is A gamma, and fast pain and temperature is A delta. Preganglionic ANS, very important. Preganglionic ANS is done by vitamin B, and postganglionic sympathetic is done by type C. Preganglionic ANS is done by type B, while postganglionic sympathetic ANS is done by type C. Very important. Whenever you see the word ANS or sympathetic nervous system or parasympathetic, immediately look after whether it is a preganglionic or postganglionic. Because if it is a preganglionic, type B, postganglionic, it is type C. Slow pain, type C. Slowest fiber, it's type C. Okay. Then type A is most susceptible for pressure, and type B more susceptible to hypoxia. Type C most susceptible to LA. Quite a 3-star rated topic, I rather say. You don't need to remember much. A little bit of remembrance is required for this. LA, it is type C, and hypoxia type B, pressure is type A. Okay. Apart from that, you have the muscle physiology. Functional unit of skeletal muscle is so-called the sarcomere. So what are the changes you may see whenever the muscle is contracting? What are the changes you may see whenever the muscle is contracting? This type of thing can be asked twice in FMGE as a negation. All of the following changes had occurred in muscular contraction except. So these type of changes, they have been given as a question of negation, people. Question of negation. So whenever the muscle contracts, your Z lines will come closer. Your Z lines will come closer, and I and H band length will decrease, and length of the A band will remain constant. Most commonly, they may misinterpret you with the, or they may misguide you with the negation question, especially with the length of A band remains, increases or decreased. That is the difference they may ask you. Length of the A band remain constant, I and H band length decreases, Z lines will come closer. Z lines will come closer. So these are the changes will happen in the muscular contraction. So you have to remember that, because they may ask you several times in the question of negations. Okay, so you have to remember that. Then muscle protein, 5-star rated to 7-star rated topic in recent FMGEs. You have to remember at any cost, muscle proteins. So we are having a 6 type of muscle proteins. So first type is contractile protein. So the contractile proteins are actin and myosin people. Contractile proteins are actin and myosin. We know that it is a thick and thin filament. And you know the contractile proteins work. While the structural proteins are all 4 proteins are important proteins in terms of structural protein. One is a titin, desmin, actinin, and dystrophin. Okay. What is a titin? Titin is responsible for elasticity, people. Titin is responsible for what? Elasticity. So whenever the titin is there, it connects your M line to the Z line. It connects your M line to the Z line, and whenever desmin is there, it connects 2 Z line. It connects 2 Z lines, and actinin will bind the actin to Z line, and dystrophin will add the strength to your muscle. Dystrophin will add the strength to your muscle. So how many are there? 4 structural protein. What are they? Titin, desmin, actinin, dystrophin. Titin maintains elasticity, while desmin is a intermediate filament which connects your 2 Z lines. Actinin is a protein which binds the actin to your Z line, and dystrophin is a glycoprotein complex which add the strength of the muscle. So which one is connecting actin to Z line? Actinin. Which one is connecting to Z line? Which is desmin. Which one is connecting M line to Z line? Which is titin. Okay, and then you have the regulatory proteins. The third category of proteins is so called as the regulatory protein. Regulatory proteins are the troponins. So speaking about the troponins, we are having 3 types of troponins. We are having 3 types of troponin: troponin C, troponin I, and troponin T. Troponin T will bind the troponin to the tropomyosin, and the troponin C, where the calcium binds with the troponin C, and troponin I inhibits the actin-myosin interaction. Inhibits the actin-myosin interaction. So CIT, C calcium. Calcium binds with the troponin C. I inhibition, inhibits actin-myosin interaction. T binds the troponin to tropomyosin. Binds the troponin to tropomyosin. Okay, then you have the relaxation protein, and then you have the Sarca pump, where the calcium pump packs to the sarcoplasmic reticulum, and then you have the Carl sequestrin, where the calcium is buffering here. So this is all about the muscle protein, people. Very, 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 very important thing you have to remember. Don't miss it. Shall we revise the muscle proteins? How many contractile proteins are there? 2. Actin, myosin. How many structural proteins are there? 4. Titin connects the M line to Z line. Desmin, intermediate filament which connect to Z line. And actinin binds the actin to Z line. Dystrophin, it is a glycoprotein complex which add the strength to your muscle. And then you have the regulatory protein, where troponin C, I, T are there. C for calcium, calcium binds with troponin C. I for inhibition, inhibits the actin-myosin interaction. And T for troponin, troponin connects to tropomyosin. Okay, then you have a Sarca pump and Carl sequestrin, which is calcium back to sarcoplasmic reticulum, and calcium will do the buffering thing. Then you have the muscle contraction. So muscle contraction, we study about all the 3 muscle contraction. We are having 3 types of muscles. So skeletal muscle, cardiac muscle, and smooth muscle. So skeletal muscle, you know that release of acetylcholine in the neuromuscular junction, and then it binds with the neuromuscular receptor, NM type of receptor. Sodium will be influx, end plate potential will be generated, and then it will passes the signal to T tubules, and then DMPR will sense that T tubule signal, and then DMPR will interacts with the ryanodin receptor, and ryanodin receptor in turn produces the release of calcium from sarcoplasmic reticulum, and the calcium binds with the troponin C of actin filament. Actin-myosin interaction will happen. Skeletal muscle will contract. Skeletal muscle will contract, and during relaxation, calcium unbinds from troponin C. Sarca will pushes the calcium back to the L tubule and then to the sarcoplasmic reticulum. So acetylcholine binding in NMJ, release of neurotransmitter, acetylcholine binds with the NM receptor, sodium influx, end plate potential generation, T-tubule, DMPR receptor sensation, ryanodine receptor activation, release of calcium from sarcoplasmic reticulum, calcium binds with troponin seed, actin-myosin interaction, skeletal muscle contract. While the relaxation, remaining calcium will be pushed back to the sarcoplasmic reticulum by Sarca pump, by the SCRCA, Sarca pump. So this is how the skeletal muscle is being contracted, people. Then you have the smooth muscle contraction. Calcium combines with calmodulin. Calcium calmodulin complex will activate the MLCK, myosin light chain kinase. Muscle contraction will happen. Smooth muscle is very, very simple. Activation of MLCK and muscle contraction. And the protein mediates the smooth muscle is a very, very important question. The protein which mediates the smooth muscle contraction is a very, 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 very important question, which is a calmodulin protein. Okay, cardiac muscle, similar to skeletal muscle, except the only fact that it can produce calcium-induced calcium release. It can produce calcium-induced calcium release. Similar to the skeletal muscle contraction, except the fact there the calcium will be released due to the ryanodine receptor stimulation. Here the calcium will be released due to the calcium induction. Okay, entered calcium will further stimulate the release of the further calcium from sarcoplasmic reticulum. That's why that is so called as calcium-induced calcium release, which is a characteristic feature of cardiac muscle. Okay, then type of mechanoreceptor, another 3-star to 5-star rated topic nowadays. Previously, it used to be the 7-star because a lot of question comes from that. But nowadays, they stopped asking because so many people are reading it. So they stopped asking it. Okay. So now, speaking about it, types of mechanoreceptor, we are having a Pacinian corpuscle, and then we are having the Meissner corpuscle. We are having the Pacinian corpuscle and then Meissner corpuscle. Pacinian corpuscles are the iron-like structure in the skin, which detects your vibration and tapping. While Meissner, non-hairy skin, velocity. Ruffini is detecting the pressure. Merkel's disc is detecting the location. Merkel's disc is detecting the location. Ruffini corpuscle is detecting the pressure. Meissner corpuscle is detecting the velocity. And Pacinian corpuscle is detecting the vibration or tapping. So Pacinian is an onion-like structure on the subcutaneous skin. Meissner, it is present in the non-hairy skin. Very, 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 very important. Especially they give you straightly onion-like structure on the subcutaneous skin, which detects vibration and tapping as dash. Pacinian corpuscle. They will ask you so much. Pacinian corpuscle. Okay, then you have the sensation. Sensation is carried out by the tract. Okay, sensation is carried out by the tract. What type of sensation is carried out by what tract are pretty important. Fine touch, pressure, 2-point discrimination, vibration, and proprioception. Vibration and proprioception are carried out by dorsal column. So I used to remember it with the mnemonic of VIPP. VIPP, vibration, proprioception, and pressure. Most people often confuses this double P with the pain. No, pain cannot be carried out by the dorsal column. Vibration, proprioception, and pressure. Vibration, proprioception, and pressure. While temperature, pain, and light touch is carried out by your spinothalamic tract. Anterior and lateral spinothalamic tract is carrying your temperature, pain, and light touch. Temperature, pain, and light touch. That's why in syringomyelia, dorsal column will be intact. Patient, when you touch him, when you are doing a fine touch on this patient can able to recognize it. But in the case of a temperature, pain, and light touch cannot be recognized. So patient is a 26 or 28-year-old female with the multiple burns in the hand and not feeling any pain or after getting a burns is a typical question of syringomyelia, where only the dorsal column will remain unaffected because the syrinx will be formed, all the decussating fibers will be compressed there. Yes or no? And only the dorsal column is not decussating in the spinal cord level. Dorsal column is decussating in medulla oblongata level, So only the decussating fiber is your dorsal column, which remain unaffected. That's why in the syringomyelia. That's why the patient comes with the multiple burn and not feeling any pain. But when you touch her, she feels the sensation. when she feels the vibration and proprioception also. Okay, so these type of things they may present to you with the syringomyelia case. So you need to know what type of sensation is carried out by what type of fibers. Okay, apart from that, you have the visual pathway. Apart from that, you have the visual pathway. That is a pigment epithelial cells will convert the Leven's retinol to all trans retinol. Leven's retinol to all trans retinol, and all trans retinol will produces the activation, and receptor cells will be stimulated. Stimulated receptor cells will transport the stimulus to bipolar cell, receptor cells to bipolar cells, bipolar cell to horizontal and amacrine cell to ganglion cell to optic nerve. Okay, so from the vision, pigment epithelial cell, when light hits on your eye, your rhodopsin will break, Leven's retinol will convert into all trans retinol, stimulates receptor cell. Receptor cells will convert into will transmit the stimulus to bipolar cell to horizontal and amacrine cell to ganglion cell to optic nerve to optic tract to lateral geniculate body of your thalamus, lateral geniculate body to geniculocalcaneal tract, and geniculocalcaneal tract to visual cortex. This is your simplified visual pathway, people. Straight to remember. Pigment epithelial cells, when light hits on them, converts the Leven's retinol to all trans retinol, stimulus to receptor to bipolar to amacrine to ganglion to optic nerve. So eye is ending here. Optic nerve to optic tract to lateral geniculate body of thalamus to geniculocalcaneal tract to visual cortex. Clear about the visual pathway? Then you have the auditory pathway. Whenever the sound waves hits the ear, it hits the ear to the external auditory canal, and external auditory canal will pushes the tympanic membrane and causes the vibration, and the vibration of the tympanic membrane will be hitting the malleus to incus to stapes to oval window, because the vibration hits one structure to another structure. Sound wave hits your ear, external auditory canal will be receiving the vibration and passes to tympanic membrane. Tympanic membrane will vibrate. Tympanic membrane will vibrate and sends the vibration to malleus. Malleus pushes the incus. Incus pushes the stapes pushes the oval window to round window to organ of cortex. Round window to organ of cortex, which is located in the inner ear. Okay, now in the inner ear, on the organ of cortex, you have the two types of membrane. One is your basilar membrane, another one is your tectorial membrane. One is your basilar membrane and another one is your tectorial membrane. Okay, two types of membrane will be there in the organ of cortex. They will undergo shearing, that is, it is moving. One is moving on anteriorly, another one is moving on posteriorly, and they crash it. Once they shear, it will produce as the potassium conductance. Once they shear, it will produce as the potassium conductance. Whenever there is an increase in potassium conductance, then there is a generation of potential, right? Yes or no? Whenever there is a generation of potential, your cochleal microphonic potential will be generated. Cochlear microphonic potential will be generated. That in turn, that potential will be passes down to auditory nerve to inferior colliculus to medial geniculate body to auditory cortex. Medial geniculate body to auditory cortex. This is how it travels, people. Sound wave hits the ear, external auditory canal will be hitting, tympanic membrane will hit, vibrates, vibration goes to malleus pushes incus to stapes to oval window to round window to organ of cortex, where the sharing of basilar and tectorial membrane happens. Potassium conductance increases, cochlear microphonic potential generated, auditory nerve will be receiving that impulse, and it transmits to medial geniculate body via inferior colliculus and then to the auditory cortex. Then you have the vestibular pathway, where you see the detection of linear and angular acceleration. So when you rotate your head, then immediately you have the horizontal semicircular canal rotation happens. Your cupula will also rotate. When cupula rotates, ciliary movement will occur. Ciliary movement produces hyperpolarization of your hair cells, and impulse will be generated. Similarly, when your head stops moving, your endolimbs will continue to move. Hair cells will be dragged to move back to the opposite direction. Again, hyperpolarization of hair cells will occur. Hair cells will occur. So this is a vestibular pathway. So all the special senses has been covered. Vestibule has been covered. Auditory has been covered. Visual pathway has been covered. Motor pathway has been covered. Sensations has been covered. Okay, now speaking about CSF circulation, how does the CSF is passing? From the lateral ventricle to foramen of Mondri, foramen of Mondri to third ventricle to cerebral aqueduct of Sylvius, cerebral aqueduct of Sylvius to fourth ventricle to foramen of Magenta and Luschka, and then to the subarachnoid space. These are the important CSF circulation. Any obstructions can lead to hydrocephalus. Now, CSF, you have a pretty questions they may ask you in the CSF. What is the circulating CSF volume? What is the circulatory CSF volume in the body? What is the circulatory CSF volume? Answer it faster, people. How much amount of CSF is produced and how much amount of circulation is happening in the CSF? Type faster, type faster. Very good. Circulatory CSF volume is 150 ml. And how much amount of a CSF produced per day? CSF production per day? How much amount of CSF is produced per day? 500 to 700 ml per day. 500 to 700 ml per day will be produced. Among that, circulating CSF volume is about 150 mm. About 150 ml. Okay. So, what is the normal pressure of your CSF? CSF pressure, normal pressure. What is the normal pressure of CSF? What is the normal pressure of CSF? 300 to 600 mm of Hg. Okay, that you can able to remember. 300 to 600 mm of, not a mercury, that is a water. 300 to 600 mm of water. Mercury goes down. Mm of H2O. Okay, 300 to 600 mm of water. Okay. Clear about that? Clear about this important MCQ? You have to write it down next to your notes so that you can not able to forget that. Okay, then you have the CSF circulation. What tracts are there? What tracts carrying what fibers are there? Spinothalamic tract, pain, temperature, crude touch. And we have the spinotectal tract, spinovisual reflex, spinoreticular olivary vestibule. All of them will be doing a proprioception. Dorsal column, vibration, proprioception, and 3-point discrimination we have done. Okay, so we have done the sensory tract. Coming back to the motor tract, speaking of the motor tract, we are having a corticospinal tract which carries your voluntary movement, rubro, flexion, vestibulo, extension, reticulo, respiration, muscle tone, tecto, auditory impulse. Among that, the highlighted ones are very, very important. Rubro, vestibulo, tecto are very, very important. Nowadays, they are trying to ask you these two also, voluntary and respiration also. So anything, even if you are remembering the dorsal column in the sensory, that is okay. But remembering each and every part in the motor, you should remember each and everything in the motor. Okay, like a cortico, voluntary, rubroflexion, vestibular extension, reticulospinal tract is respiration, tecto is auditory impulse. You have to know each and every single thing, people. You have to know each and every single thing in the case of your CS, like a motor tract and the sensory tract. Apart from that, basal ganglia pathway are there. So cerebral cortex will do the excitatory neurotransmitter to the striatum. Striatum will give an inhibitory neurotransmitter to the substantia nigra and globus pallidus. And inhibitory neurotransmitter in turn affected your thalamus by sending a inhibition of your thalamic neurons. And thalamus will produce an excitatory production. Okay, stimulation is done by thalamus and inhibition is done by your substantia nigra. So this is your direct pathway. Okay, this is your direct pathway that you have to remember in the case of your basal ganglia pathway. Okay, this is your. And apart from that, this man is a Claude Bernard, who is the father of physiology. You have to remember him. And apart from that, whenever you say like a sensory tract, dorsal column is carrying this much amount of fibers and all, I agree to that portion. The dorsal column is carrying a vibration. Yes or no? And vibration, dorsal column carries nucleus gracilis will receive the information and transmit to the second order neuron, that is your ventroposterolateral nucleus of your thalamus. And then from that third order neuron will go to the somatosensory cortex. But if I touch in the hand or in the leg, you have a different areas in the somatosensory cortex will be stimulated. That area is so called as cortical homunculus. This is your primary somatosensory cortex, where you have the region of your body on this cortex. So depending upon what areas I am touching or vibrating, that area of your cortical neuron will receive the impulse that someone had touched you. This mapping is so called as, or distorted representation of your human body is so called as cortical homunculus. Cortical homunculus. Okay, clear about that? Apart from that, this is a galvanic skin response, which is producing a sweat gland activity. Okay, so today we have discussed about the high yield areas of your physiology. And because of the anatomy we have done, we couldn't able to go through the low yield areas. But only the two areas are low yield areas. One is your endocrine physiology and another one is your respiratory physiology. Only these two we have missed. If you have covered these two, then you will be covered. So we will cover that in tomorrow. And tomorrow we can do that in the, tomorrow we can do that biochemistry also. Okay, tomorrow we can do the biochemistry and we can do the respiratory physiology and we can do the endocrine physiology also. A little bit of endocrine physiology. I mean, like we do it in the very proper way so that you can able to learn all the things. So today we have done your general physiology, your cardiovascular physiology, and we have done your neurophysiology, and we have done your GA physiology. So shall we revise for 5 minutes and wrap up the session? Shall we revise for 5 minutes and wrap up the session? Okay, we will proceed with the revision. Very fast revision, which is going to happen in another 5 minutes. So keep it. So first one, entry of calcium into sarcoplasmic reticulum is a classical example of what type of control system? Positive feedback. Okay. Deuterium, tritium, antipyrin is used to detect total body water. And Evans blue and radioiodinated albumin 125 is used to detect plasma. For blood volume, radioactive chromium labeled RBCs we uses. Okay, and apart from that, glut is an example of facilitated diffusion, which is a passive transport, which is towards the concentration gradient. Osmolarity, number of osmoles per liter of solution. Osmolality, number of osmoles per kg of solvent. And then you have the cardiovascular physiology. Phase 0, sodium influx in ventricular. Phase 0, calcium influx in the we have this calcium influx in the SA node and the AV node. Effective refractory period lasts from phase 0 to 1/3 of your phase 3 or half of your phase 3, and your relative refractory period lasts from remaining half of phase 3 to phase 0. Chronotrophy, heart rate. Ionotrophy, myocardial contractility. Dromotrophy, cardiac conduction velocity. Bathmotrophy, cardiac excitability. Lucitrophy, cardiac relaxation. Lucitrophy, cardiac relaxation. P wave, atrial contraction. QRS complex, ventricular contraction. T wave, ventricular relaxation. Okay, cardiac cycle. So speaking about the cardiac cycle, S1 is heard in isovolumetric contraction. S2 is heard in protodiastole or isovolumetric relaxation if you don't see the protodiastole. Okay, if you don't see the protodiastole, choose isovolumetric relaxation. If you are seeing protodiastole, choose protodiastole over anything. S3, rapid filling. S4, atrial contraction. A wave on the JVP indicates right atrial contraction. A wave on the JVP indicates right atrial contraction. Kussmaul sign is seen in constrictive pericarditis, massive pulmonary embolism, RV infarct, restrictive cardiomyopathy. Restrictive cardiomyopathy. And then you have the prominent Y descent is seen in tricuspid regurgitation and constrictive pericarditis. Okay. Then you have the cardiac output formula calculated from 4 sources. Direct formula, stroke volume into heart rate. Heart rate directly proportional to cardiac output, while stroke volume depends on 3 factors. What are they? Preload, afterload, myocardial contractility. Preload, cardiac output directly proportional. Afterload, inversely proportional. Myocardial contractility, directly proportional. Changes in cardiac output with the sleep? No change. Cardiac output decreases in standing from lying and on the heart disease. Formula to calculate your MAP, diastolic blood pressure plus 1/3 pulse pressure, or systolic minus diastolic blood pressure. Normal MAP is 93.33. Okay, and then you have this, what do we call it? Ejection fraction. The formula to calculate ejection fraction is stroke volume divided by end diastolic volume into 100%. Calculation of cardiac output through the fixed method, O2 consumption divided by AVO2 difference. O2 consumption divided by AVO2 difference. And indicator dilution method, cardiac output, amount of indicator injected will be on numerator, concentration of indicator will be on the denominator. What type of indicator is used in the thermodilution? Normal saline. Normal saline. Okay. Apart from the GI secretion, gastrin is secreted by G cell, cholecystokinin is secreted by I cell, and secretin is secreted by S cell, GIP is secreted by kappa cell, and somatostatin is secreted by D cell, motilin is secreted by Mo cell, and ghrelin will stimulate GH secretion. Carbohydrate digestion and absorption is happening in duodenum, lipids duodenum, and then proteins duodenum and jejunum, and then vitamin B12 ileum, terminal ileum, and iron duodenum. Highest amount of gastric acid is secretion in what phase of gastric acid secretion? Gastric phase. Lowest is seen in intestinal phase. Okay. And apart from that, you have the zymogens that are also known as inactive form of enzymes in pancreas. What is defecating reflex? Feces will produce a rectal distension, transmission of afferent impulses to sacrospinal ligament segment, reflex parasympathetic nervous system discharge, relaxation of internal sphincter followed by external sphincter, then defecation. What is gastrocolic reflex? Eating a food will produce a defecation sensation. Succus entericus is secreted by cells in crypts of Leberkuhn. Succus entericus is secreted by cells in crypts of Leberkuhn. And apart from that, you are having this, we have moved on to your nervous system physiology. Conduction occurs through the nodes of Ranvier, saltatory conduction. Myelin sheath is CNS is formed by oligodendrocytes. PNS is formed by Schwann cell. Summation potential occurs in axonal hillock. Major excitatory neurotransmitter in CNS, glutamate. Inhibitory, GABA. PNS, acetylcholine. Inhibitory, GABA or glycine. Okay, what types of ion is influx when the excitatory neurotransmitter is bound? Sodium ions. Inhibitory, chloride ions. Okay, speaking about the nerve fiber classification, what type of fiber is a slow fiber? Type C. Preganglionic ANS, type B. Most susceptible to hypoxia, type B. Most susceptible to LA, type C. Most susceptible to pressure, that is type A. And touch and pressure is carried out by A beta. And gamma motor neuron, A gamma. Fast pain and temperature is A delta. Slow pain and postganglionic sympathetic is type C. Muscle protein, structural protein, 4 types: titin, desmin, actinin, dystrophin. Titin connects the M line to Z line. Desmin connects the 2 Z line. Actinin connects the actin to Z line. Dystrophin add the strength to your muscle. Add the strength to your muscle. When muscle contracts, what are the changes occur? Z line comes closer. I and H band length decreases. Length of A band remain constant. Length of A band remain constant. Then you have a troponin C and I and T. C for calcium, I for inhibition, T for tropomyosin. So C, calcium bind with troponin C. I, actin myosin interaction inhibition. T, binding of troponin component to tropomyosin. Then you have a sarcopam, calcium back to sarcoplasmic reticulum, and then calsequestrin is a calcium buffer. Okay, what protein will mediate the contraction in smooth muscle? Call modulin. Calcium induced calcium releases seen in cardiac muscle contraction. Onion-like structure in the subcutaneous skin which carries a vibration and tapping is Pacinian corpuscle. Pressure, Ruffini corpuscle. Location, Merkel disc. Velocity, Meissner's corpuscle. Okay. Vibration, proprioception, and pressure, dorsal column. Temperature, pain and light touch, spinothalamic tract. Spinothalamic tract. And then you have flexion is carried out by rubrospinal tract, extension is carried out by vestibulospinal tract, and auditory impulse is carried out by tectospinal tract, voluntary movement, corticospinal, respiration muscle tone, reticulospinal tract. Reticulospinal tract. So with that, we have done our entire high yield areas of physiology. While the low yield areas will be respiratory and endocrine, only these two we have missed, which will take a half an hour to 40 minutes. Tomorrow we will do. Okay. With this, today we wrap up the session. So far the speed is okay, or am I going too slow? You want me to go a little bit faster? We will go from tomorrow a little bit faster. No problem for us. I feel like a little bit slow, but what about the speed for you people? If you feel like it is a little bit slow too, then you can proceed it. You can type, we can go faster. Okay, with the same speed, we can continue. Okay, tomorrow we will discuss the biochemistry and we will finish off the physiology also. Okay, we will discuss biochemistry and we will finish off the physiology. So tomorrow the session will be a little bit longer. So instead of 7:30, we will do till 8:30 the session. Okay, clear about that? We will do 8:30 the session. And don't worry, you get enough time. So read this 20 to 25 pages. Those are all very, very high yield pages. And you have to take these pages and then you have to add your own notes point. Compare your notes along with these pages. This is kind of like review, but it holds most of the information of your notes. Okay, just the 20 page, but it holds most of the information of your notes. So add the remaining information and make it very, very concise and read it like 2, 3, 4 times so that you can able to master the content in a very short period of time. Okay, all the very best. Read it good. Tomorrow, see you all people again on the same time. Okay, sure. All 19 subject will be discussed. All 19 subject will be done like this on this upcoming days. It goes till July 23. All 19 subject will be discussed top to bottom like this. We crack open, we do all the things. Okay, so have a nice day. Next session will be tomorrow at 5 to 8:30 p.m. So have a nice day, people. Thank you.